Great, thank you. Good afternoon, everybody. So talk about the little different title, but talking about the pathophysiology, but really talking about the use of medications after surgery, specifically for weight gain. And you've seen this before in my talks and recognize patient graphs like that. Again, I think an important part of your clinical practice could be having patients write out their graphs or tracking graphs like this. But again, I want you to appreciate the stability and the effectiveness over time. But we have to understand there is variability, and after people reach that nadir, whether that's physiologically where they want to be, for a lot of the mechanisms that we spoke about yesterday, there is this period of gaining back weight, which is different for everybody. You see in the groups in this study of gastric bypass and gastric band patients, there's certainly two groups in the orange and green who clearly do well, and that makes up about 40% of the group, but there's clearly a group of about 5% who just don't respond very well. And that can be represented on this graph, again, looking at bypass and sleeve patients, showing a very normal biological distribution of the number of patients and the percent maximal weight loss at that nadir weight. And there's clearly, again, people who don't respond. I show this graph and again, want to focus on the center. So weight gain has traditionally, even in a figure like this, been considered a complication of surgery. But I think what we've helped teach you, or you've already known, is that weight gain can be a very normal process in which someone gains weight after surgery. Women can get pregnant. I had a patient who was worried about her surgery not working and came in wanting a revision. And when I took a history, she had gotten pregnant 3 times over the last few years, and that may have explained why she had regained or gained some of her weight. And then you look at a patient like this who 17 years ago had a BMI of 46, and you can see just graphically that she has gained weight over time. This is, 14 years at the time this graph was done. But you see and can appreciate changes in her body weight and can think about many things that she's probably tried to do and how she's felt over this time. And I'll come back to it. But again, should we say that this is the point at which we should decide whether we should think about weight gain and decide any point beyond this arrow? Or should we take this end figure? And we got into it a little bit earlier, but the definition of weight regain or weight recurrence or weight gain really hasn't been clearly defined. And when you look at the body of professionals in the American Society of Metabolic and Bariatric Surgery, ASMBS, they haven't really come to a consensus. And I think everybody struggles with what to call that, and then questioning, after we call it something, how does that affect our management? And again, I think it's important to understand responses, and I showed you again this yesterday, so I'm not going to belabor over it too much, but this is sort of a typical pattern. You can put all the squiggly lines in there, but this is a typical pattern, perhaps what we would see in a clinic. And if they come back to you, you have to realize that they might have gotten at that point different ways, and we should investigate that as clinicians, regardless of our profession. But there's individuals who gain back weight regardless of the mechanism. Just like we see patients who gain weight before they come to see us, before they get surgery, we may not know all the answers of why they've gained weight, but we're committed to have that shared medical decision-making process in helping them through a treatment of their obesity. I had mentioned this yesterday, of getting probably 4 or 5 different periods of time where we look at someone's weight to try to best gauge how that trajectory has been. When considering the use of medications in patients after bariatric metabolic surgery, I again want you to think of 3 scenarios. One is the one I just stated. Unfortunately, this 50% excess body weight is not a clear way to assess somebody's body weight. If you think of the example of somebody who has a BMI of 100, they have a lot of excess body weight, and you compare that person to a BMI of 40, they have much less excess body weight. So if we're really using excess body weight as a measurement, those 2 individuals aren't fairly compared. So we should really use total body weight. But anyway, that suboptimal or inadequate weight loss is a phenotype, perhaps, that we should be on the lookout for. Clearly, there's people who respond very well to surgery but still have obesity. Just like people who have cancer and get their cancer removed still have some cancer that requires chemotherapy or radiation. If we think about it that way, I think we commit ourselves to continuing to treat obesity as we should, if that is our interest in our profession. And then clearly those who gain weight after a good response to surgery is kind of the basis of what this talk and other talks should focus on. And we all know the medications that you've kind of learned, but I want to focus on where they act. So certainly the bariatric and metabolic surgeries work in the gut. What you've learned thus far is that through several mechanisms of how surgery works, we know that it can change. And again, these are associations, change gut hormones. So if a sleeve gastrectomy removes 75% of the stomach, we know that ghrelin levels go down after surgery. We see that peripheral GLP-1 and PYY increase after surgery. In terms of the balloons, I put them in a device category because they don't really change the physiology. Our group in Boston did research on the microbiome, and that showed in a paper that's now 10 years old that the microbiome mix is different in people who have had gastric bypass. Whether that has a causal relationship with weight loss or weight gain, we don't know for sure. There's a lot of information about the microbiome, and I think we're all excited about it. But if you look at the data, there's not any clear evidence that that is driving somebody's weight loss after surgery. The medications, as I explained earlier today, primarily have worked in the brain and the arcuate nucleus of the hypothalamus. We know with these, there's also the oral capsules, which I don't know if they're available here, but these absorbent polymers, they're like those little sponges you put in the bathtub with your kids that increase in their size when they suck up the water. Those are put into somebody's mouth, into their stomach, and they expand, and then they disintegrate in the stomach, and it's called Plenity in the United States. But I don't think it's available here, and it really hasn't shown any strong evidence. But what I wanted to get to was this slide, in this aspect of saying these gut hormones, which we now call nutrient-sensing gut hormones, they work not only in the guts, but they also work in the brain. And I think that's obviously a promising group. I touched on this before about potential mechanisms. Again, I think I put the double asterisk there purposefully for really saying that these are still regarded as associations. And when you look at the level of evidence out there, it's still mixed. whether these things drive weight loss completely. Bile acids is another a driver that's changed after gastric bypass and sleeve gastrectomy, and I mentioned the biome. Now, obviously, if we look at the pathophysiology of what occurs after surgery, one would then say, well, wouldn't that be nice to sort of complement that with a drug, and that pairing would be perfect. For example, hypothetically, if someone has a decrease in ghrelin, why don't we give them a drug that increases ghrelin? Well, A, it's not that simple, and B, we know that the increases in GLP-1 are actually peripheral. So giving a centrally acting GLP-1 drug may be complementary. But again, we're still so early. I think the best thing that we should come away, sadly, from this talk, which I don't think is that bad, is just that we should continue to treat that person who has obesity and pick the drug that actually works and go through some of those steps that I explained earlier today. So the what and when of assessment and really this timing of adjuvant therapy, we think preoperatively, like cancer, there's this sort of this neoadjuvant use of medications, and I'll give an example of that. And then you have the metabolic and bariatric surgery, and a lot of our focus and attention has really been this post-operative stage of when to give drugs, and we would sort of call that adjuvant therapy. But the timing, should we do it 3 months before surgery? Do we think that giving a drug before surgery, and if they respond to that they're going to respond in the same fashion after surgery, or perhaps not at all? Those are always questions. Should we use that 6-month or try to best assess that nadir weight? Should we check it then? Or should we wait till they plateau, thinking that the hypothetical set point has changed and we should act then? How should we assess them? Should we use BMI and some change of BMI to sort of show whether they have not only gained weight, but they've had some recurrence of their obesity complication? And should we look at complications, the number of those? Should we look at the quality of life? And then all these sort of parameters that we don't really fully understand what the importance of measuring them are. So predicting outcomes is really what neoadjuvant therapy does in cancer models. So as I said before, does a good response to a drug predict whether they're going to have a response to surgery? You can think of a design in a study of giving a GLP-1 drug, and if they respond to it, does that make them a better responder to gastric bypass? No one's done that study. It's perhaps up to you to write the design. It would be a very good paper. And then really the selection of an optimal adjuvant therapy. Again, should we look at something that they've responded for before and say, okay, then whatever chemistry, whatever pathway, whatever hormone has changed because of that drug, maybe they're more likely to have that changed after surgery in the same fashion. This study done by Jamie Ard and colleagues a few years ago was pretty progressive in thinking. It was a prospective study, only 25 individuals, and they compared it to 13 other individuals in historic data, historical controls. They all had BMIs over 50, and they all were scheduled to get a sleeve gastrectomy, and they were placed on, at 3 months before surgery, they were placed on phentermine and topiramate combination, and they were continued all the way through surgery for 2 years. And again, they were compared to those who just had the sleeve gastrectomy by itself. So that was the design, and right above it you see the results. It's in smaller font, but you can see the green line, which was the combination therapy, did better than the blue line. For those of you who can't see that small figure, I gave you the bigger figure and the numbers. And the total body weight at 24 months after the sleeve was 27%, and after the combination therapy was 38%. Those who had gotten the medication combination were 2 times more likely to lose that preoperative weight loss and more likely to achieve a BMI less than 40. Remember, starting with a BMI of 50, so pretty good response. And the odds ratio is about 4.1. So the takeaways of this study are, should we use drugs before surgery? Do those drugs have any predictive value? Do they at least do what we see in the conclusion here, lose weight prior to surgery? Maybe that indirectly is a predictor of a response to surgery. Or do we at least get the combo effect and they do better in terms of their overall weight loss at year 2? When we talk about adjuvant therapies, we're really talking about efficacy. So some of that study showed both neoadjuvant and adjuvant. And again, I think cancer is the big comparator when we look at other disease states in which this is used. But you can see a bunch of them. And then it's been used all the way back into the 1940s when they used electroshock therapy as an adjuvant to psychotherapy in people with depression. Back to suboptimal. Again, I think we can clearly define these people, and we should. I think we should treat them differently. I think, as I gave an example yesterday and again today, I think we should use a medication thinking that for whatever reason, and again, I think you've heard two nice lectures on sort of looking at other aspects of whether the psychological aspects or nutritional aspects of one's lifestyle, and maybe those play a role in the suboptimal response. But I think at least we have to identify those patients first and then see what treatment they may need. The question is really, how long do you wait? And here's somebody from 2010 to 2006, maybe about 6 years at that plateau before a medication was initiated, in this case phentermine. But you see the response, 35% body weight loss after the medication. So that combination would be quite effective. Topiramate was used as well. So let's look at some data. This is early post-operative use of anti-obesity medications. Now again, if you ask anybody who uses medication, you're going to hear a spectrum of management styles. Some people will start at 3 months and say, well, they looked at their data and 3 months and some people say 6 months. Other people say, I'm waiting to the nadir weight, etc. Well, this one is a This one's a prospective study of 30 people after a sleeve, all still had obesity. Again, prospectively, moving forward, looking at giving liraglutide 6 weeks after surgery and looking at the data after 24 weeks. And what you see in the excess weight loss at 24 weeks, there was an improvement, the only statistically significant improvement. Interestingly, you don't see that with total body weight loss, which would be my suggestion to use. But again, that's what the conclusion of this study was. Another study done here with adjuvant therapy was a retrospective look of 117 individuals, all had a BMI over 40, and were around 8 years after. So a long period of time had elapsed before they were given drugs, and they looked at weight loss in kilograms that you see on the y-axis, and on the x-axis, months after taking. So they were taking liraglutide at different times. The investigators of the study couldn't identify exactly when it was used and for how long. So really a little bit of we would say a mixed study that doesn't really bring us broad conclusions. And even if you look at the results, Not that impressive to draw some conclusions here. Plus, half of them were gastric bands. This study was, again, late postoperative use, looking at the use of now semaglutide. So at least we're getting to a drug that has a little more efficacy. This was, again, a retrospective view of 44 individuals whose data you see there. And again, it was a very low dose of semaglutide, and that was only used for 6 months. So again, and you see categorical data there, but not too impressive between the two groups, but the drug was helpful. The Gravitas study was people who had recurrence of diabetes, and they were given liraglutide. Again, it was a retrospective look. It was a randomized controlled trial, and you see 4 kilograms, so not too impressive after 26 weeks. But again, you see and can appreciate the heterogeneity of response there, with maybe some responders, too, doing very, very well, but most, on average, maybe minimal in terms of 5% weight loss. So that's sort of the ongoing data of what to do with patients who have severe obesity and we want to treat them with drugs. Obviously, and I showed this yesterday, if they have continued obesity, I think the use of the drug is. And again, you might think, well, I'm a lover of topiramate, but at that time, we didn't have a lot of medications. And it seemed to be very effective in people after gastric bypass in my mind, and I think it was really helpful, and I still use it. But again, you see how we use the medication in this situation. And then just for the sake of time, I'll go through this, but this was, again, the use of a medication after surgery. Here we see just the use of medication. This was a 72-year-old woman who couldn't really walk very well. She had such significant osteoarthritis, and she responded very well to bypass. And she was 72, and I was kind of not too excited to give her a medication when she was about 74 or 75, I think. But she did, and I put her on topiramate like I did a lot at that time, and she got a kidney stone. So then I put her on metformin, and she didn't have diabetes, but it was really a cheap drug that she could use. And obviously, she had a significant effect of losing about 35% of her body weight. And if we go back to this patient, I want to just give you a last sort of slide of looking at how I've worked with patients over time.
Dr. Scott?
Yep, just this last slide, thank you. 40% body weight loss, so clearly a responder. She has a few children. Then she goes back and she goes on a protein-sparing modified fast, a restrictive diet, and she responds. But we know that that may challenge us in our physiology. She gets put on phentermine, then phentermine and topiramate. Then she was put on gabapentin for pain. She ends up having a BMI of 44, but not after multiple doses of the same drugs, thinking, well, if they worked the first time, maybe we should see them again. And then we thought maybe a triple therapy with phentermine, topiramate, and metformin. And then lastly, in 22, last year, that was metformin. And then last year, tirzepatide was implemented, and she got down to a 35. It's a lot of work. And you might say, well, that's not much gain, right? That doesn't look too impressive. She still has a BMI of 35, and she's on all sorts of drugs, and she still has had gastric bypass. Why not just give her surgery? But remember where she might have come from and where she might have gone if you hadn't done any therapies. So again, you might think that she's regained weight, but if you look at the delta way over to the right of where that trajectory might have gone, then you've actually done a lot of work. So keep that in mind. But again, to wrap it up, many questions do remain. First, certainly the definition of what a suboptimal response is, and I would suggest under 20% total body weight loss be the new definition. When do we initiate pharmacotherapy? We don't really know, and I gave you a couple ideas and showed you some studies there. And what is the best combination? Understanding the mechanisms of how metabolic and bariatric surgery, we don't really know, whether it's the bile acids, the microbiome, GLP-1, PYY, ghrelin, etc. But we have to still work on that. And again, how do we measure effectiveness? Is it weight? Is it comorbidities? So in summary, there's really no consensus right now to define weight gain. It's likely multifactorial, so getting a look at their anatomy, understanding if they're on any medications that might causing weight, getting your dietitians involved, getting your psychologists involved. This is always a team approach in our group. Identifying the response, I think, should be important. Maybe that can lead to productive multi-center trials moving forward. Numerous times I've shown you today and yesterday of combination therapy, so don't forget that. And again, we don't know what medication is best, so I think trying and having your patients understand that we're in this trial